Well, hello and welcome everyone to the eviCore Healthcare's Insights webinar series. My name is Bill Cornelius and I'm the moderator for today's event. eviCore empowers the improvement of care by connecting patients, providers, and health plans with intelligent, evidence-based solutions to enable better outcomes. If you would like to learn more about eviCore, please reach out to sales@evicore.com for more information. Throughout 2021, eviCore will host free educational webinars that include guest speakers, as well as eviCore subject matter experts to discuss today's most pressing healthcare topics. Stay tuned for our future webinars with new topics presented each month. Before we begin, just a quick reminder to please submit your questions using the question option within WebEx. This presentation will be recorded and it will be available on demand located on the Insights page at evicore.com. And now it is my privilege to introduce to you Dr. Sheldon Scheiner, who is our moderator today. Take it away, Dr. Scheiner.
Thanks, Bill. Good afternoon, everyone. I'm Sheldon Scheiner, and I lead eviCore's gastroenterology program. We are in March, which, as you may know, is National Colorectal Cancer Awareness Month. And so we feel that this is an appropriate time to address a critically important issue, the value of colorectal cancer screening, which, along with many aspects of healthcare, has taken a hit this past year during the COVID pandemic. We are very fortunate to have with us today highly distinguished and world-renowned experts on this topic. Dr. John Carruthers is the current Vice President and President-elect of the American Gastroenterological Association, the AGA. John comes to us from the University of Michigan, where he is the John G. Searle Professor of Internal Medicine and Chair of the Department of Internal Medicine. His research focus has included, among many other specifics, familial colon cancer, polyposis syndromes, and colorectal cancer disparities as it relates to genetics and outcomes. He is the recipient of multiple AGA Mentor Awards and serves as an editor of the highly distinguished Journal of the AGA, Gastroenterology. He was appointed to multiple prestigious national societies and is a master of the American College of Gastroenterology, as well as a fellow of the American Academy of Arts and Sciences. He had also been named the C. Richard Boland Distinguished University Professor at the University of Michigan. And not by coincidence, we have Dr. C. Richard Boland. Rick is a professor of medicine at the University of California, San Diego School of Medicine, and has had a career-long research interest in colon cancer, specifically focusing on the genetic causes of colon cancer and familial cancer syndromes. While at the University of Michigan, he studied the molecular genetics of colorectal cancer, and he gave the name Lynch syndrome to a particular hereditary cause of cancer. His laboratory developed the first in vitro models to study the basic biology of Lynch syndrome, and he was among the first gastroenterologists to explore microsatellite instability in cancer. He has published over 400 papers, was president of the AGA as well, and has also received multiple national recognition awards and medals. Last and not least, we have on our panel today our own Dr. Joseph Weiss. Joe earned his medical degree from Wayne State University and completed a clinical and research fellowship in gastroenterology at the University of California. He is a clinical professor of medicine at UC San Diego and is a frequent speaker at universities, medical schools, hospitals, and pharmaceutical companies. He is the author of several respected books, including such topics as colorectal cancer screening. He is a fellow at the American College of Physicians, the AGA, and the American College of Gastroenterology. It is a distinct honor and privilege to welcome our three panelists to our webinar today. I should like to begin by asking the panel to address how common is colorectal cancer and why is screening valuable? I would ask our panelists to engage in a back and forth discussion, to chime in with their thoughts, and we can start with John.
Thank you, Sheldon, and thank you for the wonderful introduction and for having us as a panel today. There are about 150,000 cases of colorectal cancer in the United States annually, with just about 50,000 deaths. So it's pretty common. And if you rate that in relationship to other cancers we screen, even though prostate cancer and breast cancer have more incident cases than colorectal cancer causes more deaths than those two cancers annually. The other thing I'll say is that breast cancer and prostate cancer are gender-based or sex-based, whereas colorectal cancer is more of an equal opportunity.
Rick?
Yeah, so what that comes down to is that about 4 or 5% of the population will get colon cancer, and it's exponentially related to age. And interestingly, there's been, over the last 10 or 20 years, there's been a steady decrease in the incidence of colon cancer and consequently a fall in the mortality too. But that's mainly occurring in the older people, and it's going up in younger people under the age of 50 for reasons that we really don't understand. And the reason that probably the incidence has been flattening in the older populations because of screening, but also because of changes in lifestyle. There's less smoking, and people are less likely to have a high-fat, meat-based diet. So it's constantly in flux too.
Thank you. Joe?
I would add in that when you're asking how common is colorectal cancer, I would answer much too common. It is unfortunate that it occurs as often as it does. And part of the real discomfort in still looking at the numbers we're talking about, as John mentioned, we're talking about 50,000 deaths a year from CRC in the U.S. alone. If you take a look at worldwide, this is a major issue. But the tragedy is that it is so preventable, and screening can make a big difference in bringing those numbers down. As Rick mentioned, fortunately, the mortality rate has dropped because particularly screening has played a major role in that, identifying these cancers early, where the survival rate is much higher. If you catch it early, as with screening at stage 1, we're talking about 90+% survival rate. When you catch it later, it's an avoidable tragedy. So we can do a lot more, and we really should be doing a lot more to bring these numbers down. And in the younger population, unfortunately, it is increasing in incidence. It's a growing concern. So just because you're younger than 50, and I think that's wonderful to be younger than 50. I wish I were back there again. There is a higher risk. There's actually an advantage to being a bit older. So maybe there is some return on the investment of age.
Thank you. Screening is even more important and valuable in higher risk populations. Who is at higher risk? What histories inform us of this risk? And how is screening different in these populations? We can start with Rick.
Well, first of all, as I said before, age is the principal determinant of risk. But as I said, also that's been changing. Men have a 30% more risk for colon cancer than women. And there's one of the big problems is that we have a fairly sizable segment of the population who doesn't get screened for reasons that we'll discuss eventually. And those folks, there's a higher risk for colon cancer, and the mortality is higher too. And one of the big things that's going on here is that by starting in the late 90s, we began to do screening colonoscopies. And so a lot of polyps were taken out. And that's probably part of what's going on, is that by taking these polyps out, then we're actually avoiding a person actually developing a cancer later. So we're constantly having these interventions that are changing the outcomes.
Yeah, I think that's. Oh, go ahead. I'm sorry. Yes.
No, I was just going to add to Rick's that I think of colon cancer causing changes in certain populations. It's a genetics and environmental, I'll say, synergy or balance, if you will, or interaction, I should say. There are some high-risk populations. Some of them have genetic causes, direct genetic inherited causes, that is in a surveillance group. The other group are the people that we found colon cancer in already, or high-risk polyps, and they are at risk for developing a second colon cancer or additional polyps. And we put those people in a different group that we call those surveillance. So, but the largest proportion is what I call average risk population who don't have any of that. And I think the genetics plays a little bit less direct role, although it's playing a role, but it's the environment. And when I say the environment, it's the things that Rick mentioned. These are the things you eat, your diet, the high-fat diet, your smoking, and those types of things, because that modifies things in your own gut that literally bathe these cells with different levels of exposure that can alter ultimately the genetics to cause colon cancer. And we know some of these things are much higher risk for patients. And that's what we're trying to find when we say average risk for those who don't have the big genetic causes.
So I want to add one other thing here, and that has to do with the genetics issue. So everybody if you have a first-degree relative who's got a colon cancer, that increases your risk. And sometimes, actually a pretty small proportion, it's due to one highly penetrant mutant gene that you have. But more often, it's just a matter of positive family history, which represents probably a lot of shared genes and shared environment and lifestyle factors. So for every additional first-degree relative you have with a colon cancer, whether or not you can find a gene that's responsible, that increases your risk. And the younger that person was, your first-degree relative, then that risk goes down. Interestingly, there was a study some years ago from Utah that said if you didn't have anything, if you had no first-degree relatives, but you had only a second-degree relative with colon cancer, your risk was actually lower. So it's really the first-degree relatives that count.
I might add that we've been talking about some of the risks, and certainly genetics, family history is important. We've also alluded to the importance of diet and avoiding red meat, processed meats, if you would, reducing alcohol consumption, avoiding tobacco usage. There is a connection with obesity and weight issues. But in spite of all of these risk factors that have been identified, I would suggest that one of the biggest risks is basically ignoring the opportunity to get screened. I think the biggest risk is people simply saying, you know what, it's not that big a concern. I mean, it's about a 90% chance I'm not going to get colorectal cancer. Why get screened? Well, the reason is because there's about a 4 or 5% chance that unfortunately and tragically you will. And boy, if you miss out on that opportunity, you're going to be kissing your life goodbye. So get screened.
Yeah, I think screening is the great equalizer, and we can talk about more in certain populations, but this is one of the universal recommendations, no matter what your population is to get screened. So.
Thank you. Next question. We are going through a very traumatic national experience with COVID. How has this affected screening strategies and outcomes? And what should we expect to see at the other end of the pandemic in terms of colon cancer?
So maybe I'll start with that. You know, the COVID-19 pandemic that engulfed the globe has been tragic, a lot of deaths. And at least when the pandemic was started throughout the world, a lot of preventive services were put on hold, including other services were put on hold, largely because of the high rate of transmission of this virus in all settings. And as a result of that, if you look at data from about March through June or July of 2020, and I've seen data from Europe and the United States, the amount of colon cancer screening dropped almost 90% from its pre-COVID levels. Now it started picking up in the summer of 2020, but it hasn't quite reached back to pre-COVID levels just yet. It's approaching there. Now there's data that also shows that even with a 6-month delay, and this was a combined breast and colon cancer analysis, that a 6-month delay over a 10-year period will give you 10,000 excess breast and colon cancers. So delay of preventive services has, it was, I would say, a necessary thing at the start of the pandemic because we didn't understand fully the scope and how to control COVID to the best we could. But delaying preventive services will cost lives down the line. And so I work in a health system that is trying to put that at the forefront, that preventive services are safe to do in the middle of COVID to reduce your risk from dying from another disease, in this case, colon cancer, down the line. So I'll turn it over to another panelist there.
John? No, I'm sorry, Rick.
I agree with what John said, and there have been several studies that are mainly simulation models, and every one of them says that we're going to lose lives by not doing this very simple screening. And it's understandable why places had to shut down because there's a lot of contact between the physician and the patient and the nurses and everybody else if a person comes in who's carrying the virus. So we've got a problem. We may have to make some adjustments over the next, once we get out of the pandemic, to kind of roll that risk back.
I'll add just to Rick's comments that most places, including a place where I'm at, we test people usually a day or so before they get their colonoscopy for COVID. If they're COVID positive, they will get delayed until they clear the infection. If they're COVID negative, the colonoscopy is performed. And there's also recommendations from many of the GI societies on the adequate protection for those performing the procedure, if that's the procedure they're getting to get screened, which is the most common in the United States. So there are some precautions there up front.
Well, another thing too, John, is that at the University of California, San Diego, the use of protective equipment has been very effective. And the number of people who are in the nursing and the technician lanes, their risk of getting infections has been surprisingly low because everybody's really careful. So those things work. Those things work.
Yep.
I think it's important for people to realize we're beginning to open back up again now. Certainly COVID shut things down, and it is a tragedy, no question about that. Not only the loss of lives with COVID, but the people who have not been screened, who are lost to the risk of colorectal cancer, they're projecting thousands of deaths because people have not been screened over the past year. But we're beginning to reopen the screening opportunities. But I'd also comment that besides colonoscopy, there are other ways to get screened. So one can also get screened using FIT, or multi-target stool DNA analyses. And these are non-invasive, home-based. It can be done through the mail. So even if we're missing the opportunity at colonoscopy, there are other ways to keep the screening up to avoid the tragic loss of life from the pause because of COVID.
And Joe, you bring up a highly important point, because earlier it was mentioned about certain populations. We talked about high-risk genetic populations, but even within the average risk populations, there's variations based on your racial ethnic background. And so we know that, for instance, African Americans and Native Americans have higher risks of polyp generation, these high-risk polyps, as well as earlier ages and risk for cancer. And during COVID, although the data is not fully solid, but the fear is that even though there was a slowdown in the general population of colon cancer screening rates, it's even going to be much harder in underrepresented or some of these more disparate populations, and that disparity may revert back to where we were 5 or 10 years ago, when the rates were markedly different between, let's say, screening for African Americans compared to a white patient. And those numbers have been slowly, the gap of differential screening has been slowly closing over time. but most experts fear that COVID has been an unequalizer again.
Just to add to what John and Joe were saying, let's say we recognize that we have a certain backlog of people who we were doing colonoscopies on for surveillance because they had advanced adenomas before or whatever. And we recognize we may not have the manpower to do colonoscopies on all those people. Using an FIT is a very good alternative because it's close to 90% sensitive, and so you can safely delay the colonoscopies on the people who have negative FITs until you catch up. So, but you have to keep doing it on an annual basis. That's the key thing.
And as Joe, I'm sorry, go Joe.
Well, I was going to comment that the disparity is a real tragedy between the different groups of our population. We are all and should be treated the same. I think that when you're commenting that screening is a great equalizer, I wholeheartedly agree. And maybe that, again, is FIT may be an advantage because it's so available and can be easily distributed and should be taken advantage of. I'm sorry, John, continue, please.
So the key to that, you're right. Some of these non-invasive tests could be mailed, so they have to go into a certain site. There's no real prep, and you're right. It's a great screening tool. The key is the follow-up because most people will be negative, but there will be a handful of people who are positive, and the positive test requires a colonoscopy. And so the key is going to be the follow-up, no matter what population you're in. And there's data out there that suggests certain disparate populations have a lower rate of follow-up for a positive test. And so that's the key thing to make it continue to be a great equalizer for screening.
Thank you. We have the changing demographics of colorectal cancer in the younger population, as well as healthcare disparities, which we alluded to just now. How has this affected screening strategies and outcomes?
Well, how about I'll take a shot at that one. So as we mentioned earlier, there's been a rise in the rate of colon cancer among people under the age of 50. It's still a pretty small number, but 7% of the deaths due to colon cancer in 2020 occurred in people who were under the age of 50. And so there have already been, it's a split decision, but several of the recommending groups have said that you should start doing some kind of screening, presumably FITs, at age 45 to pick this up. And and interestingly, these tumors tend to occur in the distal colon and rectum. So you can imagine that there's more than one way to go after that. You could use sigmoidoscopy even, but FIT is probably a very acceptable way to go. And an FIT is more likely to be positive with a more distal lesion because the blood's going to be on the surface of the stool.
Right. I'll just add that particularly in the young onset, this appears to be a generational change. Prior to 1990 and people born before 1960, the rates were low to flat to even dropping. And then people born after 1960, so 30 years later when you're 30, starting in 1990, the rates started going up, and for unknown reason. Although I've seen some data now that, Rick mentioned earlier lifestyle, and I think Joe mentioned obesity. There's some data out now showing that if you separate out those who had obesity versus none without obesity, it's the obesity ones that are really driving the increase. Although that is still, I'll say not a rock solid driver, but there's some data that suggests that because everyone's trying to search what is the etiology. But the key would be can we catch these people? And now it's going to come down to doing screening at a younger age. And there's been some endorsement of that from some of the GI societies and the American Cancer Society. And it's being evaluated by the U.S. Preventive Service Task Force to go at age 45. But that's going to catch a good percentage of them because they tend to be closer to 50. But it's going to miss the ones. I've seen 30-year-olds with as best we can tell, sporadic cancer. It would never catch that person. So we don't have a clear strategy yet to catch those people. other than if you get symptoms, and we know that when you get symptoms, you're already probably further along, and when it's harder to save you. So this is something we have to figure out and how to address that population fully.
You know, one of the things that we should keep in mind too is that I think it was pretty easy at one time if a 40 to 50-year-old came in with a bellyache or seeing blood in the stool to say, oh, it's irritable bowel syndrome or it's a hemorrhoid. And we probably now should take any of those alarm systems very seriously in a younger person.
Absolutely.
I would add to the comments, and John, I thank you for bringing up the obesity issue again, because I think, if you'll forgive my play on words, it's the elephant in the room. When we're wondering about why are the younger population at higher risk for CRC now, I think the obesity issue is the elephant in the room. And 75% of the U.S. population today is overweight or obese. That is a staggering number. There's also suggestion that less physical activity may be playing a role. Obviously, alcohol, tobacco can play a role. But I would suggest that perhaps the FIT may be an answer again, because when we're looking at screening the younger population, every time you lower the age for screening, the cost goes up, because colonoscopy is a screening utility, is labor intensive, resource intensive, it is expensive. And somebody up there is calculating the cost-benefit ratios, and they are coming back with what is a life worth. My feeling is that every life is worth a lot. And if you can use a relatively inexpensive screening modality, such as FIT, maybe offer the FIT at an earlier age and start there as a lower-cost way to initiate the screening. And if a 30-year-old has a positive FIT, I would send them for a colonoscopy.
Sure, and people have proposed those types of strategies. There's one other dimension I should mention. You know, I mentioned earlier about, you know, the disparities, and there is plenty of data that goes back multiple years showing that in African American population tends to present somewhere between 3 and 7 years younger for cancer, and they develop polyps at an earlier age. The interesting thing in the increase in young onset colon cancer, the biggest increase has been amongst white populations and some Latino populations. And it's almost like they're catching up to the earlier age of some of the African American populations for whatever reason. And so the data is that the disparity for young is growing in white, young white patients, again, for some of these particular possible reasons that Joe mentioned.
I think one other thing to keep in mind, and it's a tragedy, that Chadwick Boseman, the great actor, unfortunately and tragically died from colorectal cancer beginning at young onset. He was 39 when the CRC began, and it was too late, and he was dead just a few years later. And again, he's young, he's African American. It does not discriminate. CRC, unfortunately, is too common.
Yeah, it's in all populations, and without finding it earlier, it will kill you.
Yeah. Thank you. Next question, and just to let everybody know, we are receiving questions from our audience, and we will get to them after we complete the round table. This is a very important question as well. We remain below the minimum goal of screening 80% of the risk population. Why is there such a large gap in compliance and adherence to guidelines when the value is so clear?
I'm happy to start with that. You know, if you look at screening for any type of cancer, it has never reached 100%. You know, and so 80% is a laudable goal for those who are eligible. So your question is, why haven't we reached that? In the United States, we've reached about 65% across the board. The United States strategy has been largely based on colonoscopy. If you compare us to other countries, some other countries have used FIT as their strategy. And even within the United States, some health systems have used FIT as their strategy, like the Kaiser system has done. I think there are, why have we reached 80%? There are some barriers to that. Some of them are provider barriers, some are patient barriers, and some are systemic barriers. So give you an example of a provider barrier. What if a provider doesn't, for some reason, recommend screening, no matter what your background is, it's unlikely to get done. And there's data that some providers still don't recommend it, which is almost unfathomable at this day and age. Some of it's the patients. Some patients, we can talk about the variety of tests, but some patients have heard, okay, a relative got a colonoscopy and they didn't like the prep, so I don't think I want to do the prep. But there's other reasons to, other methods to do the screening as well. So that takes a discussion between the provider and the patient. And then I'll say some are systemic problems. For instance, we mentioned about FIT testing, which stands for fecal immunochemical testing. This is a stool-based test that has to be done yearly. And so most insurances, it's a very inexpensive test. Most insurances will cover it. But if you have some type of limited insurance, it may cover it. But if it turns positive, your screening is done, but now you need a follow-up colonoscopy. And in many cases, there may be a copay because that colonoscopy is no longer a screening because you had a screen test. It may be charged as a diagnostic colonoscopy to follow up that screening test. And in some cases, some people will have to pay an out-of-pocket cost. And that is a barrier for some people. And I think there's a lot of policy advocates trying to change that, because I'm a big believer that whether it's a negative or positive test, the screen is not done until the full completed evaluation is done. And to me, if it's a positive test for FIT or multi-target stool DNA, you have to have a colonoscopy that's positive. If it's negative, fine, we're done. But if it's positive, the test is not fully done until the colonoscopy is done. That's just my personal view.
Yes.
I would add that I think one of the reasons that there's a lower utilization of screening is to some degree social. I think many people are embarrassed by the idea, oh my gosh, it's my bowels, and we're talking about stool specimens and colonoscopy, and it's something I don't want to talk about, and they put it behind them, excuse the play on words again. Not a good idea. There was I think a great campaign a number of years ago that said, don't die of embarrassment, that colons, bowel,
very good advice.
As part of human nature. Get over it. And for those who are concerned about the discomfort talking about stool, hopefully, in tragedy, you'll never come down with it. But if you do have colon cancer and you do end up with surgery, or if you end up with tragically a colostomy, I mean, the stool test, a colonoscopy, is nothing compared to what it's like to go through colorectal cancer. For those who don't know about it, it's not a pleasant way to go. So please do get screened.
And along that thinking, Joe, these tests are highly cost-effective for society. Study after study, and this is why it's recommended by all the cancer societies, the federal government and CMS, all the GI societies, and this is how we practice, that screening for colon cancer is definitely cost-effective. It is more cost-effective, surprising, than breast cancer screening. And we talk a lot about breast cancer and mammograms. But screening for colon cancer is one of the most cost-effective preventative measures for any cancer screening of the human body. And that's been shown time and time again. And, you know, earlier when we were talking about disparities, it is the most cost-effective in African Americans, by the way, because they develop polyps earlier and cancers at an early age. So screening catches them and saves what we call life years saved in these analyses. And they will gain more life years saved because it's found at that earlier stage. But it is highly cost effective across the board.
Absolutely. I share with patients that I think this is the cheapest form of life insurance you will ever find. And it's the right type of life insurance. You're not paying a premium so someone else gets the benefit. This is where you get the benefit.
Yeah,
Absolutely.
And by the way, essentially all the tests, we haven't talked about all the types of tests. You know, in the United States, we call screening, there's first tier tests, and this is recommended by the Multi-Society Task Force for colon cancer screening. First tier tests are what you've heard about a lot, is the FIT test and colonoscopy in the United States. And as I said, other countries some have chosen colonoscopy and are FlexSig. Others have chosen FIT as their main strategy. So those are the first tier tests. When you get to second tier tests, which are still very good, these include flexible sigmoidoscopy, which will only look at the lower half or lower third of the bowel. It also includes CT colonography, which I would say many people in the United States use as a surrogate when they can't do colonoscopy for a lot of comorbid reasons. But it is an approved screening test, and there's some other issues with it because you have to still take a prep. It's only diagnostic, not diagnostic and therapeutic. And then the multi-target stool DNA test, of all the analysis of those, all of them do a good job in detecting cancer. They, depending on the test, there's a variable level of detection for the precursors, the polyps, which is what you really want to find before it turns into cancer. And then one of those tests, which is the multi-target stool DNA test, is a little bit on the a little bit less cost effective than the other tests, but it still does a good job in screening. So all these tests can save your lives.
Absolutely. I would just add one other comment about colonoscopy, that we're a little bit different than most of the world, that we do use colonoscopy more than they do in Europe. It's the #1 screening study in the U.S., but we have one other advantage for the consumer, for the patient. We offer sedation or anesthesia. Many places around the world don't offer that. So colonoscopy with sedation, don't even remember it. So it's not a big deal.
That's right.
I would suggest that the preparation is more involved than the procedure itself for the consumer, if you would.
Yes. Thanks. Just Dr. Boland has a little technical issue. So he's attempting to rejoin. So hopefully we'll be able to get him back. I apologize for interrupting. I just wanted to let everybody know.
If he warned us ahead of time that when his wife gets onto her video programs, the bandwidth doesn't quite cover it. So I'm sure there's a little discussion going on at home.
Let me then go on to the next question. And when Rick gets back on, we'll ask him to comment in general about these issues. What strategies are best for the various stakeholders? For example, insurance carriers, providers, and health departments in making best efforts to reach out to underserved populations and to get them screened?
Yeah, that's a challenge. So, I'll say some things pre-COVID and COVID. So the first thing I will say is that there's been 2 large studies. The best known is the Delaware Health Study that shows they compared Black and white patients, and the Black patients had a lower utilization of screening, as is seen nationally, even though that gap had been closing prior to COVID. And they did a 9-year study and gave something called navigation. So navigation means you had someone, typically from the community, in the health center or the hospital, that help guide whether you were white or Black through getting, in this case, colonoscopy. And it was an amazing study because the rates for a Black screening at the beginning of the study were much lower. They had higher incidence of cancers rates in the community, and higher mortality. By the end of this 9-year study, both blacks and whites rates for screening went up. The disparity for incidence of cancer disappeared, and the disparity for mortality had approached disappearing between the two groups. So that study tells us a lot. That study tells us navigation works for everyone because it floated all boats. It was, as I said earlier, the great equalizer because it got rid of the disparity over time. But you have to work at it. You know, once we stop screening, polyps will come back and grow. So this is something that has to be an ongoing effort. So that was a wonderful study. So how can various stakeholders get underrepresented screened? Well, one is to make sure that the any of those tests that have shown it can reduce incidence and mortality are covered by your insurer. Second, that this is that the providers that you pay your insurance premiums to, insurance payouts to, are following the guidelines that essentially every cancer society, GI society, and the federal government recommends for screening. But for specifically targeted underrepresented populations, I think it has to get down to the community level. When I used to be in San Diego, and I mentioned this to Joe in the past and Rick in the past, that because of the issue of being converted from a screening test to a diagnostic colonoscopy, it's a barrier for some, and particularly it's a barrier for those who tend to have less insurance coverage, which tends to be more the underrepresented populations. So that somehow needs to be covered, or the out-of-pocket cost needs to go to zero so they can complete the test. The second thing is that the availability of those tests need to be around. So whether it's colonoscopy or FIT or flexible sigmoidoscopy, those tests need to get done. So that it really comes down to addressing the community practices, education across the board, and getting people on regular screening schedules. So I don't know if Joe, you want to add any more to that?
I would agree with you that education, access, all of these are really important, but I'd also add one other comment, that sometimes there are different groups that have different biases, perspectives about how they would like to be approached. And we're talking about don't die of embarrassment and dealing with stool, colonoscopy, sigmoidoscopy, etc. Offering a variety of options to let the members, the patients, decide along with their healthcare provider what would be the best approach for them. Giving them a sort of a cafeteria plan of options may also increase access and utilization. So for those providers who say it's colonoscopy or nothing, there's another viewpoint. You might want to consider offering your patients the option of an alternative approach that may encourage them to get screened, because the best screening test is the one that gets done. So whatever we can do to increase that utilization, and that obviously includes the outreach to the community and the coverage from the insurance companies. This is one preventable cancer, and it is cost effective. For the insurance companies, it is so much better to offer screening than to end up paying for the treatment of colorectal cancer.
Absolutely.
There's no question there's a savings.
Yeah, by 2019, so this is pre-COVID, in the United States, this is American Cancer Society data, 65% of white Americans had gotten some form of screening in the previous 10 years, and it was about 62% of African Americans in this case. There was no data on Native Americans or Hispanics. But if you looked at the data 10 or 15 years ago, that gap was more like 8%, so they had come down. So the problem is COVID. COVID put a hard stop on things, and now we've got a ramp up trying to get back to normal. And again, my biggest worry is that it's going to recreate that disparity, because there's if you look at who's getting vaccinated, which populations are getting sick, there is more trepidation in some of the more underrepresented communities than in the more represented communities, and then getting follow-up care. So one is COVID, but two is the follow-up of fallout of the consequence of COVID, which is reduction in preventative services. So that's going to be a challenge. This is where if there's still connection with the community and their doctors, that mail-in test that Joe brought up, these other tests might come into play, as long as if it's positive, it's followed up on. So
Right.
you can mail a FIT test, they can do that at home and mail it out, they don't have to come in, or a multi-targeted stool DNA test, they can mail it out. Most insurances do cover both of those tests with a varying, but the key is, if it's positive, will they get the follow-up colonoscopy? That is the key.
Do we have statistics on how many people do not follow up a positive test?
Yeah, I don't have the, from my perspective, and others can answer, I don't have the numbers on top of my head, but I do know the data shows that even with, so from the PLCO trial, I believe it was the trial that showed that there was something like a 10 or 12% differential between African Americans and whites from follow-up after positive tests. And then there was another study done out of Beth Israel Deaconess, which showed that even if someone had frank blood, which is a alarm symptom, that's not screening
Right.
anymore,
Right.
that African Americans were less likely to follow up with that for colonoscopy. So we have some work to do. That's a symptomatic red flag there. But even with a positive test, a non-invasive test, there was a differential. So
let me apologize for having been off the air for a while. I missed probably about 10 minutes of the discussion here, but so I'm sorry if I repeat something that's already been said. But
no
the issue of underrepresented minorities getting followed up is a complex one, and it involves not only issues of access, but also trust as well. And so there was a study from Mount Sinai that showed that using a patient navigator had a big impact on getting people followed up, getting them screened and getting the follow-up done. So there are ways around this, but we need to have a diverse representation among our providers, and we need to earn the trust of these communities, which, we have to reach out and do that.
I would add one other comment too, that many people are afraid of a positive result and what that might mean, and they are hesitant to come in because they're afraid something might be found. I think if we encourage them and share with them, the majority of positive FIT tests or occult blood tests are not colorectal cancer. There's another reason for that. And if there is something there, putting your head in the sand, the traditional ostrich approach, is not going to make it go away. And if you can catch it early, boy, is there a big difference in survival rates and what you can expect. So don't hesitate. But it's an education, and there obviously is a real disparity that needs to be addressed, and that's going to take work, but it's absolutely worth doing, and we should be on top of that as far as encouraging every way we can to get the communities screened.
There's a study that's going to come out in Digestive Disease Sciences that I just wrote an editorial on, so it's already accepted. So I don't recall the authors, but it was actually, the issues of fear and fatalism came up, but it wasn't the strongest driver. They looked at, this was African-American men, some who had gotten screened, some who had not, and they questioned them. They had these different surveys. And the biggest driver for the ones that got screened was provider recommendation. Okay, it was unbelievable strong, more than fear and fatalism. And the ones that didn't get screened, the majority was that my provider didn't recommend it. It wasn't on the docket. So this is a huge thing that's coming out in some of these surveys. The other thing is that these were African-American men. And so they were trying to figure out what was the message that could increase their chances of getting screening. And a lot of it had to do, one of their strengths was on masculinity, like I am the provider for the family. I need to keep myself healthy to get this test. So that was an interesting study that's going to come out in DDS soon.
I'm going to go to our last question, and we can spend some time on this. We've alluded to it in answering some of the other questions, but I think it could do with a little clarification. There are many options for screening, which we talked about. How do we help the average patient decide what is best for them? They are often confused by data and statistics. What should they be looking for in helping them to make the best decision for themselves?
Joe, you want to start?
That's a loaded question, but it's a great one. It's complicated enough as it is on our side as gastroenterologists to decide what is the best approach. Most people would say go with colonoscopy because it offers not only the ability to screen, to diagnose, but to be therapeutic. You share that with the patient, but there's also a risk, there's an expense, and it's not the most comfortable things to go through. There are alternatives which are less invasive, and some of them are fairly simple to do, such as the FIT or the multi-target stool DNA test. There are other options as well. So from CT colonography, capsule colonoscopy, there's a variety of options. I think what we do best is to encourage them to get screened. Find the approach that you feel is most comfortable. We make recommendations, but it's the member, the patient, who really has to decide, because if they're not on board, it's not going to get done. And I think the best we can do is share with them the pros and cons, offer them the options, and encourage them to get screened.
I'll add, just briefly, we live in the United States of America. We have urban populations, we have rural populations, we have reservation populations, and there's some rural areas that there's no gastroenterologists around to get a colonoscopy. So I like what Joe said earlier in the discussion, that's the best test is the test that gets done. So your options might be more in an urban or suburban setting for that, and with good health care, plenty of people who can do the variety of tests. But in some cases, that's not the case. And even in some dense urban areas, as well as in some pretty rural areas, where some of the more, I'll say, higher diagnostic and therapeutic type tests like colonoscopy are harder to get at. And so as long as you have access to one, if you have a positive of the non-invasive test, I think that's key. So in the United States, the strategy has been largely colonoscopy, but there are populations that use FIT a fair bit. But as long as they have access to colonoscopy, maybe not to the same rate as doing a lot of colonoscopies as the screening tool, but as the follow-up to a positive test, that as long as that's available, I think that's fine to use any of these tests in the United States.
Rick, any additional comments?
No, I think that Joe got that just right. You've got to size up the population that you're dealing with, and then figure out the best way to convince them to go along with that particular strategy. And we also need to keep in mind too that whenever we do a non-colonoscopy test, basically, we're at the screening test for who gets the colonoscopy. So people need to understand that at the end of the line, it's going to be colonoscopy, and that's powerful because you can remove pre-malignant lesions too. So, I can't argue with anything that was said by John and Joe here.
Thank you. We have just a few minutes for questions from our audience, so I'll go through them. One is from a non-physician, and I think it's an interesting question. With many using probiotics, are there any studies, pro or con, on how they affect changes in the GI tract, and I'm guessing that this is in reference to your risk for colon cancer, as we did touch a little bit about how the environment of the colon really does affect your risk.
Let me address that, because I was going to say something about this earlier when I was kind of lost my internet connection here. There's a third player between the host, the person who has a colon, and the environment, whether it's the diet or tobacco, and that's the microbiome. And so it's really the microbiome that creates an environment with metabolites that probably is a big driver of cancer. So at this point in time, I mean, probiotics are being used all over the place, but the data aren't very strong that it really changes outcomes yet. But once we get, it's possible for us to link certain microbes to certain cancers because of the mutational signatures that are in there. And the techniques are now available to study this. And I think we're going to solve this problem in the not too distant future, so that we'll be able to see what can we put into our diet that will change the microbiome and the internal environment in such a way that it will reduce cancer. And there's certain bugs that have a very specific mutational signature, and they are associated with a higher risk of colon cancer. And someday we're going to figure out how to get rid of those, how to displace them with other bugs. So we'll get there. We're just not there yet.
Yeah, I agree with Rick. The other thing with probiotics is it permanent or not? Because oftentimes you have to take these probiotics, and now you think of things that affect the colon as lifestyle changes. So you either have to take the probiotics for a lifetime, just like you change your diet over a lifestyle. We've learned from the inflammatory bowel disease that probiotics can modify, but once you stop the probiotics, things come back. And so the permanent change was the fecal microbiota transplantation. But we're getting smarter on how to package these probiotics. So there's probably going to be some innovations in the future that can modify it on a more permanent basis.
We can do it in mice.
I would add one other comment.
Yes, you can do it in mice.
I had one other comment about probiotics, that they've become extraordinarily popular, nearly like a fad, if you would. And we're still so early in understanding about the gut microbiome. And as Rick mentioned, we haven't identified which bugs do what yet. So while there are probiotic products out there, I would suggest you might save a lot of money by just going and eating well, having good, healthy foods, organic foods, going to a farmer's market, getting your probiotics the natural way until we sort out which bugs are which, because we really don't know.
Well, I think we're reaching the end of our time. And unfortunately, I don't think we can take additional questions from the audience, so I apologize for that. This has been an enormously illuminating and informative discussion with regards to the importance of screening for colorectal cancer. I hope that the discussions have been enjoyed by our audience. I know I've enjoyed it, and it has been an honor to me personally to be part of this discussion. I would like to thank our panelists for their contributions today, and I look forward to having them back to visit us in the future. Thank you all very much, and I will turn this back to Bill. Thank you.
This concludes our webinar. This webinar was recorded and will be available on demand by visiting eviCore.com. Please remember to register for our upcoming webinars. You will receive an email invitation with the opportunity to do so. Thank you again to our panelists for sharing your expert knowledge with us today. Thank you all for your attendance and your insightful questions. This concludes our webinar. Have a great day.
Thank you.
Bye.